Hello, welcome to my channel. I'm Dr. Drabian, radiologist. This is a sonography-radiology training channel. I will present different videos could be benefit for physicians and general population. This is the 7th video about imaging findings in leukemia, mostly about thoracic imaging findings of leukemia and its complications. In previous video, in part 1, I speak about these sections, and in this video, part 2, I will explain other thoracic imaging findings of leukemia, including myeloid sarcoma, pulmonary alveolar proteinosis, amyloidosis, role of PET-CT, and final teaching points. Myeloid sarcoma is not diagnosed commonly in the thorax. However, in intrathoracic myeloid sarcoma, the mediastinum is the most common site of the involvement. Mediastinal myeloid sarcoma may manifest as a focal mass or as diffuse infiltration of mediastinal soft tissues. Case presentation: myeloid sarcoma of the thymus in a 24-year-old man who presented with right shoulder pain. Shoulder MRI revealed a mediastinal mass, and chest CT was performed for further evaluation. This axial chest CT shows an anterior mediastinal mass, and fused PET-CT image shows the mass to be FDG away, and the biopsy result was consistent with myeloid sarcoma, and the patient received a diagnosis of AML. Less commonly affected sites include the lungs, pleura, pericardium, and hyla. Another case presentation of myeloid sarcoma of the right upper lobe in a 62-year-old man with AML. PET-CT image shows an FTG await right upper lobe mass, which biopsy result revealed myeloid sarcoma. Involvement of bones, soft tissues, and the breast is not uncommon. Evaluation of the breasts is important because myeloid sarcoma can involve the breasts bilaterally and may be visible on chest CT images. Myeloid sarcoma has a strong predilection for subperiosteal and perineural involvement. Another case presentation: 37-year-old woman with acute myeloid leukemia after bone marrow transplant who also had bilateral myeloid sarcomas of breasts. Axial fused FTG PET-CT shows bilateral hypermetabolic breast myeloid sarcomas. Another case: 50-year-old man with AML who underwent matched sibling bone marrow transplantation. Coronal fused FTG PET-CT image shows hypermetabolic enhancing soft tissue extending along left T1, T2 intervertebral foramen, consistent with spread of myelogenous leukemia deposit along nerve root. Coronal contrast enhanced image shows enhancing mass in T1, T2 intervertebral foramen, which is more readily appreciated after review of fused FDG PET. Another section of thoracic imaging findings of leukemia is pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis, or PAP, is a rare condition characterized by intra-alveolar deposition of periodic acid shift positive lipoproteinaceous material secondary to an inability of macrophages to clear degradation products of surfactant. PAP may be congenital, primary or autoimmune, or secondary. Secondary PAP occurs in association with malignancies, most commonly hematologic malignancies of myeloid origin. Among the myeloid malignancies, it occurs most commonly in CML than in AML. Another cause is infections, for example HIV, inhalation, exposure, and immunosuppressed states, for example after hematopoietic stem cell transplantation. Symptoms of PAP may include cough, progressive dyspnea, and respiratory failure. CT findings include ground glass opacities with or without interlobular septal thickening. When the ground glass opacities are associated with interlobular septal thickening, the appearance is known as the crazy pawing pattern. Now a case presentation: PAP in a 39-year-old man. Axial Untitled CT image shows patchy bilateral granules opacities associated with interlobular septal thickening. As I told in the previous slide, PAP is associated with CML, most common cause, but also may be seen in ALL and CLL. Given its relatively non-specific appearance, PAP can be mistaken for a typical infection, so persistent opacities after appropriate antibiotic therapy should raise the suspicion for PAP. The association of PAP with opportunistic pulmonary infections such as nocardia and pneumocystis pneumonia has been described. Another section of thoracic imaging findings of leukemia is amyloidosis. What is the definition of amyloidosis? Amyloidosis is a group of diseases resulting from the extracellular deposition of fibrils composed of low molecular weight subunits of various proteins, which is a rare complication of CLL. The principal types of amyloidosis are immunoglobulin light chain amyloidosis and amyloid A amyloidosis, famous as AA amyloidosis. Immunoglobulin light chain amyloidosis is characterized by the deposition of immunoglobulin light chain fragments and occurs in patients with underlying plasma cell dyscrasia, for example, multiple myeloma. Amyloid A amyloidosis is characterized by the deposition of serum amyloid A, which is an acute phase reactant and occurs in conditions that are associated with ongoing or recurring inflammation, for example, rheumatoid arthritis, inflammatory bowel disease, and chronic infections. Both immunoglobulin light chain and AA amyloidosis have been reported with CLL. About 0.6% of all patients with amyloidosis who were seen in one institution over a period of 4 decades had CLL. In the thorax, amyloidosis can affect the lungs, pleura, airway, mediastinum, or hilum, and the heart. There are two patterns of pulmonary amyloidosis: nodular parenchymal form and alveolar septal form. Nodular parenchymal amyloidosis manifests as solitary or multiple pulmonary nodules that may calcify and slowly enlarge. Now, a case presentation: nodular parenchymal amyloidosis in a 67-year-old woman. This chest X-ray shows several pulmonary nodules, predominantly in the right lung. Unenhanced chest CT shows that one of the nodules at the right base is of predominant soft tissue attenuation and contains no calcium. However, the patient had a known history of amyloidosis. When not calcified, such discrete and effective amyloid deposits named amyloidomas may mimic primary or metastatic malignancy. Another case, chest X-ray in 82-year-old woman with nodular parenchymal amyloidosis due to marginal zone lymphoma. In addition to calcified mediastinal adenopathy, multiple calcified nodules are present bilaterally. Unenhanced chest CT in the same patients show that some of the nodules are partially calcified. One of the nodules has a partially speculated margins. Several partially calcified and non-calcified nodules, many with speculated margins, are present in the right lung. Differential consideration include pneumoconiosis, granulomatous infections, and sarcoidosis. Biopsy of the right lower lobe lesion shows parenchymal amyloidosis. Another type is alveolar septal form. Is characterized by small, about 2 to 4 mm nodules accompanied by reticular opacities, interlobular septal thickening, confluent consolidation with peripheral and basal predominance. Another case presentation: unenhanced axial CT image of chest in 68-year-old woman with systemic amyloidosis associated with monoclonal gammopathy. Several areas of interstitial septal thickening, predominantly peripheral and basal consolidation, patchy granules and parenchymal micronodules are all compatible with alveolar septal pulmonary amyloidosis. These imaging features are non-specific and the differential diagnosis is heavily dependent on the clinical presentation, ranging from pneumonia to malignancy with lymphangitic spread, but pulmonary amyloidosis was proven at wet biopsy in this patient. Pleural involvement in amyloidosis usually manifests with pleural effusion. In terms of airway involvement, long segment concentric trochal narrowing is characteristic. Now a case presentation. A 64-year-old woman with amyloidosis after airway requiring tracheostomy. In this soft tissue window from tracheal CT image shows concentric thickening of the trachea, including the posterior membrane, but no calcification was seen. At exhalation, areas of air trapping are seen. And sagittal image confirms long segment involvement of trachea. Mediastinal and hiral involvement consists of multi-station or localized lymphadenopathy that can demonstrate a variety of calcification patterns including punctate, diffuse, or eggshell patterns. Another case presentation, amyloidosis in a 65-year-old woman with CLL and progressive right supraclavicular adenopathy at clinical presentation. Axial CT image shows right supraclavicular adenopathy containing punctate calcified foci. Cardiac amyloidosis in one study of 33 patients with both amyloidosis and CLL, about 20 of them had cardiac involvement and 1 had lung involvement. Low-grade primary pulmonary lymphomas, for example B-cell CLL, SLL, can have secondary amyloid production. Cardiac amyloidosis is evaluated best with cardiac MRI. The left ventricular wall is typically thickened with associated diastolic dysfunction. Delayed contrast enhanced imaging characteristically shows diffuse subendocardial or transmural enhancement. Another case presentation, cardiac amyloidosis in a 79-year-old man with progressive symptoms of heart failure and left ventricular wall thickening on echocardiogram. Short axis phase sensitive inversion recovery image of the basal left ventricle 15 minutes after AIV GAT injections shows diffuse subchondral and patchy atypical myocardial enhancement, and steady state free MR image at the same level show concentric ventricular wall thickening. Subsequent endomyocardial biopsy shows a type of amyloidosis. And the last section of this presentation about thoracic imaging findings of leukemia is rule of PET-CT. PET-CT is used routinely in the diagnosis and staging of malignant diseases including hematologic malignancies and especially lymphoma. In terms of leukemia, FDG PET-CT is useful in the detection of extramedullary involvement in acute leukemia, myeloid sarcoma, and Richter transformation in patients with CLL. Extramedullary involvement may be present in up to 30% of patients with AML and has been reported increasingly in patients with ALL. Now a case presentation, extramedullary leukemia in a 40-year-old man with ALL. Full body PET image shows FDG-await extramedullary lesions involving pleura. Pleural biopsy results confirm the diagnosis of ALL. Because some extramedullary lesions cannot be treated adequately with standard chemotherapy and requires more intensive chemotherapy or allogeneic hematopoietic stem cell transplantation, identification of extramedullary involvement, especially recurrent extramedullary disease, is critical. Extramedullary recurrence presents a poor prognosis and usually is diagnosed when disease is widespread. Therefore, for early identification is important to improve outcomes. PET-CT is sensitive but not specific for diagnosis of extramedullary disease in patients with acute leukemia. In a retrospective review of 79 patients with either newly diagnosed or suspected recurrent acute leukemia showed the sensitivity 93, specificity 71, accuracy 80% of PET-CT in diagnosing extramedullary involvement. PET-CT provides early identification of lesions that are clinically occult or not detectable on conventional images, direct the optimal biopsy site, and serves as a method to assess patients' response after therapy. A case presentation: 55-year-old woman with acute myeloid leukemia who also had blastic transformation for myeloproliferative disease. FDG PET maximum intensity projection image shows conglomerated hypermetabolic nodule mass at the left supraclavicular fossa and hypermetabolic infiltration of left kidney. This axial view FDG PET-CT image shows corresponding left kidney infiltration. After induction and consolidation chemotherapy follow-up, FDG PET-CT examination shows complete resolution of the disease. PET-CT is a useful prognostic and diagnostic tool in patients with CLL and suspected Richter transformation. Another case presentation: Richter transformation in a 55-year-old man with CLL. Axial PET-CT image shows retroperitoneal adenopathy with an maximum standard uptake volume of 2.7. The patient developed progressive fatigue, fevers, and left-sided abdominal pain and fullness over a course of several weeks, and Richter transformation was suspected. Follow-up axial PET-CT image shows increasing retroperitoneal adenopathy with an SUV max of 17.7. Biopsy result revealed classic Hodgkin lymphoma consistent with Richter transformation, which is a type of Hodgkin lymphoma variant. Patients with different CLL phases but a similar SUV max have similar outcomes. Nodal biopsy, especially core or excisional biopsy, is the diagnostic procedure of choice to ascertain CLL transformation definitely, and PET-CT is important to identifying the sites that are most likely be diagnostically informative. A cutoff maximum standard uptake volume of greater than or equivocal to 5 on PET-CT images was shown to have sensitivity 91, specificity 80, negative predictive value 97, and positive predictive value 53 for diagnosing of Richter transformation. As a result, when Richter transformation is suspected, biopsy of a lymph node with an SUV max greater than or equal to 5 is recommended. And these are the final teaching point of this long presentation about thoracic imaging findings of leukemia. While lymphadenopathy is the most common manifestation of leukemia in the thorax, leukemia also may involve the lung, pleura, pericardium, bones, and soft tissues. Pulmonary complications in patients with leukemia usually are due to pneumonia, hemorrhage, edema, or drug toxicity. However, there are several cases of pulmonary disease that are related directly to leukemia, including leukemic pulmonary infiltration. Pleural and precardial effusion in patients with leukemia are more likely to be benign than malignant. Myeloid sarcoma is a mass consisting of myeloid blasts occurring at an anatomic site other than the bone marrow and represent a rare presentation of AML. PET-CT is useful in the detection of extramedullary involvement in acute leukemia, myeloid sarcoma, and Richter transformation in patients with CLL. Awareness of spectrum of intrathoracic manifestation of leukemias enables radiologists to play an important role in optimizing patient treatment. These are references I use for this presentation. If you like this video, please subscribe this channel. If you would like to get notification for the next videos, please press a small bell. If you have any question or video suggestions, please write in the comments. Thank you for your attention.